So after delivery, there are a number of events which lead to the closure of the ductus. One is that the placenta is removed, which is the main source of prostaglandin production. Second is that as the lungs expand, there's more blood flow to the lungs, which in itself is an organ which metabolizes prostaglandin. Um, and then what happens after delivery is that the fluid from the lungs is removed, which decreases pulmonary vascular resistance. And because the umbilical cord is clamped and the placenta is removed, systemic vascular resistance increases. So this causes the shunt to now change from right to left to a left to right direction. And then with the onset of normal respiration, what happens is there's increased oxygen partial pressure in the blood, and oxygen itself acts as a trigger for the smooth muscle in the ductal tissue and causes it to constrict and eventually close. One reason why the ductus may fail to close in preterm infants is that one, they have a higher amount of prostaglandins, and two is that the premature ductal tissue is less sensitive to oxygen. Moving on about how to diagnose the PDA. So there are physical exam findings along with diagnostic tests. So in the physical examination, there is a classical continuous machinery murmur, which can be heard below the clavicle, also radiating to the back. Along with that, a prominent precordial impulse can be palpated. There may be a high heart rate. Bounding peripheral pulses can be seen, which is due to the increased cardiac output. There may be a widened pulse pressure, which is due to a high systolic pressure due to the increased amount of cardiac output, and a decreased diastolic pressure due to the diastolic runoff, in which the blood is flowing in the reverse direction in the aorta. Along with that, you may see rapid breathing, shortness of breath, and difficulty feeding. So, diagnostic testing, we have chest X-ray, echocardiogram, and electrocardiogram. A chest X-ray in a small PDA can be normal, but in larger PDAs, it can show us cardiomegaly, especially left ventricular hypertrophy, and it can show enlarged pulmonary arteries and prominent pulmonary vascular markings due to the increased pulmonary blood flow. The echo is used to assess the PDA to see its size, the direction, and the volume of blood flow, and we can also see pulmonary overcirculation. And the electrocardiogram again can be normal in smaller PDAs, but in larger PDAs, it can show signs of left ventricular hypertrophy. And if the baby develops pulmonary hypertension, then it can show signs of right ventricular hypertrophy. And if there is ischemia or supply-demand mismatch, we can also see T-wave inversion and ST depression. So next, we will talk about what is a hemodynamically significant PDA. And this is important because deciding whether it is hemodynamically significant or not is also important in deciding about the management of the PDA. So when we're trying to assess whether it is or not, there are three things we're looking at according to the recent article published by the American Academy of Pediatrics, which include one is clinical presentation, second is assessing the PDA, the shunt itself, and third is myocardial function. So the clinical criteria consists, we have 4 criteria, and 2 out of 4 at least should be fulfilled. So the first one is high CPAP or non-invasive mechanical ventilation with a high FiO2 or moderate or high ventilator settings at any FiO2 level. Second is hypotension requiring the use of a vasopressor. Third, we have persistent oliguria or renal dysfunction. And fourth is abdominal distension, feeding intolerance, or if there's a history of developing necrotizing enterocolitis. So for the echocardiographic criteria, we are assessing the shunt size, looking for volume overload, for pulmonary overflow, and systemic hypoperfusion. For the shunt size, we look for the diameter of the PDA, which should be more than 1.5 millimeters. Second, we're looking at the flow pattern. We want to see the direction and the volume of blood flow. For volume overload, we will see an increase in the left ventricular output, and the left atrial to aortic root ratio will be more than 1.5. And this is because due to the increased blood flow, the left atrium can dilate while the aortic root size remains relatively same. Pulmonary overflow can also be assessed by These two, as well as end diastolic flow in the left pulmonary artery. And then for systemic hypoperfusion, we see the flow through the descending aorta, which can be reversed, reduced, or absent. And we see the organ flow, which can be hypoperfused. We have the same thing written over here. And next, we will proceed to the complications, which Elise will continue.
Fatma, can you go back to the previous slide?
Yes, sir.
And how about you read it one more time for audience to just get a grasp of it? Thank you.
Okay. So this is the echocardiographic criteria, and one of these criteria needs to be filled. So there's the diameter of the PDA, which should be more than 1.5 millimeters. There should be a left to right transductal flow, left-sided volume overload, which can be seen by the left atrium to aortic root ratio, the left ventricular output, and the enlargement of the atrium or the left ventricle. And there is the flow through the descending aorta, which can be decreased, absent, or reversed. Elise?
Okay, so I'll be speaking about the complications associated with patent ductus arteriosus alongside the management for patent ductus arteriosus. So the first complication that I'll be speaking about is congestive heart failure. Fatma, can we move to the next slide for this one? So in preterm infants, even moderate shunting can tip the balance towards congestive heart failure. And this is due to underdeveloped diastolic function and also because of immature myocardium in preterm infants. What is happening over here is that a persistent PDA is going to cause a left to right shunt. This left to right shunt is eventually going to lead to an increase in blood volume that will be returning towards the left side of the heart. So over time, what we're going to see is that there will be a volume overload causing left-sided heart failure. In neonates, we're going to see signs like tachypnea, poor feeding, failure to thrive, and also pulmonary edema. The next complication that is often associated with patent ductus arteriosus is pulmonary overcirculation. So in case of persistent PDA, there can be prolonged ventilator support and it can cause complications in respiratory management. What's happening is that blood flow from the aorta is shunted into the pulmonary arteries. As a result of that, we're going to see an increase in the pulmonary blood flow. An increase in the pulmonary blood flow eventually leads to fluid accumulation within the lungs, and it causes pulmonary vascular congestion. So in neonates, you may see an increase in the work of breathing. There will be more frequent desaturations, prolonged ventilator dependency, and also chronic lung disease in preterm infants especially. So another complication that may be associated with PDA is infective endocarditis. Now, I do know that infective endocarditis is uncommon in neonates generally, but the anatomic defect that poses alongside a long-term uncorrected PDA, especially in hemodynamically significant cases of patent ductus arteriosus, it's going to lead to an abnormal turbulent blood flow across the PDA. And this turbulent blood flow causes a damage to the endothelial surfaces. So these damaged endothelial surfaces end up becoming a nidus for bacterial colonization. So even though it is rare in the neonatal period, PDA increases a lifelong risk for endarteritis. And when I say this, I actually found a very interesting case report that was based out of rural India. So a 10-year-old girl with uncorrected patent ductus arteriosus was diagnosed with infective endocarditis. I've attached the imaging, but I don't want to go into a lot of detail about how the infective endocarditis was diagnosed, just that it was seen on transthoracic echocardiography. The purpose of putting this slide over here is just to show and highlight the importance of prompt diagnosis using echocardiography and the importance of prompt management of patent ductus arteriosus, because an uncorrected PDA might be leading to complications like infective endocarditis in later stages of life for these infants. Fatma, can we move to the next slide? Thank you. Okay, so the last complication that I want to speak about is Eisenmenger syndrome. So even though Eisenmenger syndrome is rare in infancy, it is a devastating late consequence of untreated PDA. And this, again, reinforces the need for timely closure in appropriate cases. So what happens in this case is that chronic pulmonary overcirculation is going to lead to pulmonary vascular remodeling, and that is going to result in an irreversible pulmonary hypertension situation. complication. So once the pulmonary pressure is going to be increasing the systemic pressure, the shunt that we have that was initially a left to right shunt is going to reverse itself into a right to left shunt. And this is going to result in cyanosis. An important thing to know over here is that once the Eisenmenger physiology actually develops, PDA closure is contraindicated then, because PDA closure at that point is going to risk sudden cardiovascular collapse. So now that we've spoken about the complications associated with PDA, I'm going to touch upon PDA management. Now, PDA management really depends on when should PDA even be treated, right? So according to the AAP guidelines, the decision to treat really depends on whether the PDA is hemodynamically significant or not. And Fatma has already touched upon what we mean when we say hemodynamic significance of PDA. So in preterm neonates, especially those under 28 weeks, a large PDA can significantly affect the systemic perfusion and the lung function. However, the AAP also emphasizes on a more individualized approach when we think about treating PDA. So we have to kind of balance the risks of treatment with the potential for spontaneous closure, which may occur in several cases. But a stepwise approach would generally be once we've established a hemodynamically significant PDA, we move towards the medical management, evaluate the response to that medical management, and then think about intervention. So when I speak about medical management, we start with cyclooxygenase inhibitors like indomethacin and ibuprofen. What these cyclooxygenase inhibitors are going to be doing is that they reduce the prostaglandin synthesis, which naturally is going to be promoting ductal closure. Ibuprofen is usually preferred due to the low risk of necrotizing enterocolitis and renal dysfunction. And an alternative to the cyclooxygenase inhibitors would be paracetamol or acetaminophen, which is often well tolerated and used in cases where NSAIDs are contraindicated or have failed to show better prognosis. And if this pharmacological management is also often supplemented with fluid restriction and with other supportive management. Fluid restriction's primary goal is to reduce the pulmonary overcirculation and the symptoms of congestive heart failure. And when I talk about supportive management, I'm talking about optimization of oxygenation and ventilation and use of diuretics like furosemide to decrease the overall fluid overload in the body of the infant. So next we have surgical or interventional approach. This is something that we move towards if the medical management has failed. Then that is when we can consider interventional approach, or when the PDA is very large and symptomatic. So there are two main options for this. The first one being transcatheter closure and the second one being surgical ligation. Transcatheter device closure is usually the preferred method for older infants, for children, for adults. Usually in very low birth weight infants, transcatheter closure is not preferred. It does have fewer complications than surgery. It has a minimal risk of vocal cord paralysis or bronchopulmonary dysplasia that could be associated with surgical ligation. So in older infants, transcatheter closure is usually the way to go as opposed to surgical ligation. Can we move to the next slide? Okay. So in cases where transcatheter closure fails or medical therapy has also failed, and in very preterm infants with large symptomatic patent ductus arteriosus, we can think about surgical ligation. Surgical ligation is effective, but it carries risks such as post-ligation hypotension, vocal cord palsy, and it can also lead to potential long-term impacts on neurodevelopment. I did find a study, a retrospective comparative study that was done in a pediatric cardiology center in Pakistan. I've summarized the results of this study in this slide, and the study was basically comparing transcatheter device closure and surgical ligation. There were a total of 250 patients in this study. 120 of them underwent transcatheter closure, and 130 underwent surgical ligation. Overall, what the study showed was that both methods were highly effective. However, the device group ended up having 0 residual shunts after 1 month, but the surgical group had a small residual rate of about 1.5%. When we talk about the complications associated with both procedures, notably the surgical group had major complications, including bleeding and infection, and the device group had reported almost none. For hospital stay as well, the device group had a much shorter hospital stay as compared to the surgical group. When I speak about the cost effectiveness, the study showed that the device procedure was about 16% more expensive And for the mortality rate, it was notable that no deaths were reported in either of the group. So it highlighted that both the options were overall safe when it was done properly. So this is all that I have. It just shows like there is still need for trials that can link hemosignificant patent ductus arteriosus, closure timing with long-term neurodevelopment outcomes, or we do need more evidence needed, for optimal timing of the transcatheter closure. But based on what we already have, the data that we already have, this is what it shows. Thank you so much for taking out the time to hear this presentation with us. I hope you enjoyed listening to it as much as Fatma and I enjoyed presenting it. Thank you.
Thank you, Fatima and Lisa. This was an excellent presentation. I want to comment a couple of things. One is about, as I said, like this was amazing, and you guys have done a wonderful job preparing for this. But I want to share with you a couple of thoughts I have. One is transcatheter closure. Now we are actually doing it on as small as less than 1,000-gram baby. So it has been moving like, downward, like even smaller babies, you can do transcatheter closure nowadays. And we do that, especially those babies who we have tried other things and nothing worked, and then we go for it, especially in centers where they have people who can do it. So that is one thing. And let me tell you, at Columbus, where I am, with Nationwide Children's Hospital, they have something they call pivotal trial, and it's ongoing. And our center is part of that trial. So they are actually looking at the data by doing those transcatheter closures, and probably we will know in a couple of years. And my feeling is this is going to get popular because I think the main problem is they are slowly sorting out the problems with transcatheter closures. So they're having less complications. They're having more people with skills to do it. So that is one thing I wanted to comment on. So the other thing is the surgical closure, the surgical ligation. I hardly have seen a surgical ligation now. Like, I think the last time I saw a surgical ligation of PDA, as far as I know, in my NICU where I work, was more than probably 5 years ago. One baby we had it, and most of times what nowadays they do is we call surgical ligation, but basically they clip it. So there is no they don't ligate, they clip it. And I will share you a funny story about it. We had a family who wanted nothing external inside the baby, so they were declining transcatheter closure, and they opted for surgical ligation and ended up having clipped with that external device. So it was funny that they were trying to avoid something to be inside the baby and left, and they ended up having that. So yeah, I mean, surgical ligation is kind of misnomer now. We hardly, I think Nasser would agree with me. And Nasser, have you seen surgical ligations for a while?
So first of all, thank you very much, Safdar and Khalid, for providing us with the platform for these young graduates who are now at the cusp of entering into the residency, inshallah. As I mentioned, Fatma already had a scheduled interview with UNLV. They know about this presentation, and they will hopefully be watching it at a later time. But these two girls worked very hard. I don't know whether they want to brag about it or not, but let me brag about on their behalf. They both worked very hard. They extracted data on 10 patients from our baby steps to look at the outcomes. And they were willing to do more, but we are still waiting for the permission to extract that data and utilize it for a publication later on. But I completely agree with Safdar that the ligation, surgical ligation, I haven't seen one for the last 8 years. But I will tell you that one of our general surgeon who used to do the surgical ligation of the ductuses had a terrible complication about like 10 years ago, when during the clipping, the thing with the clip is that it's a very simple procedure. Like it seems like a very simple procedure. You go in and you put the clip on, but when you release the clip, you have to make sure that the clip is all the way to the other end and not compressing the ductus. And somehow there was a miscalculation, and the clip was released early. And when it was released, it got stuck in the middle, and the ductus started bleeding, and it bled, and that poor infant died on the table. So that was one of the complications that, although we think it's a very simple procedure, can happen. And the surgeon is an amazing surgeon. It was just one bad day that it happened. Luckily, family was very understanding, and they were fine at the end of the day. Obviously, they lost their child, but they were very understanding. Now, one thing I just want to add on, and I want Safdar's opinion on that, is that the units that have evolved into Ensure and Lisa and are extubating these babies early on, those babies are not meeting the criteria for hemodynamically significant PDA, even at the 7th to 14th day and beyond 14th day. So, honest to God, and I can show my data, and these girls have extracted 10 of those. And they hopefully will be able to continue with that when we get the permission from the Mednex and our parent organization, is that we stop treating. Like, we do not even treat with ibuprofen or anything, because our ductuses are so inconsequential hemodynamically, because these babies are not on terrible vent support. They are on NIPPV or CPAP. And usually they are growing well. Their flow in the aorta is not compromised. There's no feeding intolerance. So all those things that would let us to treat it, we are not treating it. And last but not the least, Safdar, you tell me when was the last time you wrote for indomethacin? I think the last time I wrote was about like 18 years ago. So I don't know when was the last time you wrote for endo, which we used to use like a TikTok, like a chewing gum in the NICU in old days. So I don't know. Safdar, are you guys still using indomethacin or no?
No, we are not using. I agree. I just for the students here, the pendulum for treatment for PDA has swung multiple times. Like initially, what used to happen is the indomethacin was popular. It is very potent, but it has a lot of side effects. Then ibuprofen came in, became popular, but then people became a little bit suspicious of side effects with ibuprofen. So then now we have Tylenol or acetaminophen, which is also very popular nowadays. But lately, I have to say, we are not actually treating PDA, most of the PDAs, even hemodynamically significant. We wait and give enough time for spontaneous closure. And I have to say that, in Pakistan, for example, most of the babies which at birth, they are more than 28 weeks because of the, survival issues. So most of those babies, they have very high spontaneous closure rate. You don't really need to treat those babies. Some of them, obviously, there are always some babies who will need some treatment. But I will say a big number, a big percentage of them, they will not require any treatment, even if they have large PDA, even if the baby has like a PDA, which is in first week of life, looks like, oh, it's a huge PDA. You wait it out for like a week or two, most of them, they close on their own. And if you have to treat it, you basically start with, if you look at the AAP guidelines, they usually want you to wait more than 2 weeks and then do something about it. So yeah, I mean, I agree with Nasser that we're not using indomethacin at all for a long time. I haven't used it, but I even forgot when was the last time I used it. But we used to use a lot ibuprofen, and now recently we're using more of Tylenol. And as I said, in our center, we also consider strongly about transcatheter closure. And we also have actually a specific PDA team, which actually, screen babies who will qualify for transcatheter closure, and they will reach out to us, hey, you want to consider closure with transcatheter closure option. So yeah, I mean, things have been slowly moving away for the treatment for PDA. This is what I have to say, and it has to do with what Nasser is saying also, like all these Lisa and better management at birth, not fluid overloading right in the beginning. All these things play into it. But I think this is a good discussion. For
So,
many of
so
you, it might be boring because
yeah, so a couple
what
of
these
things.
guys are talking about.
Yeah, so there are two things. First, I really like to thank Dr. Sajjad because this is pretty late over where he is. Dr. Sajjad is also on the meeting, and all the students who are on this group should know Dr. Sajjad is one of a very renowned neonatologist in Saudi Arabia, and he has a very large group of neonatologists on a WhatsApp group where we do clinical discussions and everything. So besides me and stuff, that I think, Dr. Sajjad, would you like to add a few more things? And then Dr. Saima Pirzada has a question that I will post for both of you, Elise and Fatima. Dr. Sajjad.
Hello. Yes, thank you very much, Nasser. Thank you very much. I really enjoyed this presentation. Very, very nice presentation and very nice comments by yourself and by Dr. Safdar. And I agree, we are not very much into treating duct too aggressively. And I think we have forgotten about the indomethacin. Probably more than 15, 16 years we haven't used it at all. And we either use Tylenol or ibuprofen. And again, only in hemodynamically significant PDAs. We did have few cases, 2 or 3, in which we did the device closure. But I don't remember anyone with the surgical ligation recently, in last many years. I think that's all my comments are. I think as a whole, the session was very good and very nice presentation by your junior doctors. I appreciate it.
Thank you, Dr. Sajjad. So the question is from Dr. Saima Pirzada, and she wants to know, do we still give furosemide? Elise or Fatima, would you like to answer or you want me to answer?
I'll definitely let you have the final word on it. But from my understanding, as much as I read up on it and from what I've seen, it's not something that is like primary therapy for PDA, but it's used in a very limited amount and like an adjunctive role to take care of like the pulmonary edema and more like for symptomatic relief.
And you said it very well. Absolutely. You don't need my editorial comment. And thank you very much for that. So the other question from Dr. Ubaid Riyaz is that, and I'm going to read it for both of you. And if you want to answer, fine. Otherwise, I'll end up answering, or Safdar can answer. If hemodynamically significant PDA is present with reversed end diastolic flow in descending into aorta, should we continue feeding?
Sorry, Nasser, can you repeat the question?
So the question is that if the PDA is hemodynamically significant and there's a reverse or end diastolic flow in the descending aorta, should we continue feeding or should we stop?
That's a very tricky question. And if you look at the practice, it varies a lot between different NICUs. I will be very extra cautious if you have reverse diastolic flow to actually do aggressive feeding, like advanced feeding aggressively. The other aspect is, and I have a personal bias. And if you look at it, Nasser, during my fellowship, I published mainly on PDA anti-pro-BNP as a fellow because that was my primary project.
Mm-hmm.
And one thing I learned digging through the literature was that all these treatments which we give for PDA, for example, ibuprofen, indomethacin, Tylenol, they all also inhibiting many good prostaglandins too.
Yeah.
So what happens is that when you do that, you actually further compromise the blood flow, especially to the kidneys, to the intestine. So on those babies where you have reverse diastolic flow, and if you on top of it gave a medication which actually clamps down your perfusion, that can be a problem. In my personal experience, I'm always extra cautious when we are treating a baby on which you see reverse diastolic or end diastolic flow on echo. And I'm, you know, again, if this is a baby who is a big baby, like more than 28 weeks and at birth, versus a baby who is born at 24, 23 weeks, so they behave very differently. So that factors also into your planning. Whatever I say, please don't take it word by word, because I practice in a very different environment where we manage even 22 weeker, 23, 24 weeker, which may be very different in terms of their behavior or clinical course. If you compare with a baby who is in Pakistan, who is a big baby at birth. So I think a lot of times when we say things here from US, and they should not be taken literally because the context is different. We're talking about different populations. A 23-weeker will never behave like a 29-weeker in terms of PDA. This is, I have a strong belief. So yeah, I mean, if you have a reverse diastolic flow in a 29-weeker, I probably will not be as much worried. If I have a baby who is a 23, 24-weeker with that same kind of finding, then I'll be very extra cautious to actually even throw on things like ibuprofen, Tylenol, and even feeding. I will be slow on feeding advancements. So my 2 cents, Nasser.
Yep. Well, these are not your 2 cents. These are like Bitcoin. So my 2 cents are coming now. So there is a follow-up question from Dr. Khadim. He is actually working in Peshawar in a NICU. And he said, thank you for this educational seminar. Question is that their cardiologists are still using indomethacin in their hospital. And what should we do about that? So Dr. Khadim and anybody who's practicing in Pakistan, first of all, somebody's mic is on. So can everybody mute their mic on their end, please? So that we cannot hear the background noise. When you have a question, just unmute yourself. Otherwise, mute your mic, please. Thank you. So Khadim and rest of the folks who are practicing in Pakistan, I would say that at your level, when you are an intern, I think coming from you and saying, hey, don't use indomethacin because I heard Safdar saying it's not a good medication, will not go well. I think what you need to do is to present the article that has just recently came out, which is the American Academy of Pediatrics Guidelines on PDA Management, and initiate a conversation with your cardiologist and your group and say, hey, this is a more recent recommendation, so why we are still using indomethacin. And they may have a reason. They may be cost reason, non-availability of ibuprofen or acetaminophen in the liquid form. I don't know. I am not there, so that's my first response to that. And then there is a follow-up question from Dr. Ubaid Riaz. Thank you for your question. I'm going to read that question. And Alize and Fatma, you will try to answer. And then if not, then either me, Safdar, or anyone else can. If managing PD in conservative manner, like fluid restriction, how much fluid should be restricted? Example, on a day 7, and above taking 150 ml per kg per day, how much low we should go? Should we go to 120, 130, or 100? Any specific number, or just according to the fluid balance? So Alize and Fatma, would you like to answer this question? First of all, did you understand that question?
Yes, I did.
Yeah,
Okay. So Safdar, why don't you go ahead and answer this question?
Yeah. So let me, give you background on these PDA guidelines. Remember that PDA, as I said, has been back and forth multiple times over the years, decades, I would say. And honestly, I feel a little sad that this is an area where we have, as a scientific community, spent so much money, and finally the AEP came up with guidelines. This is very rare thing AEP comes like that. because they realize we are spending so much money on PDA, but we are not coming up with something conclusive. And that's why they came up with these guidelines this year in 2025. My suggestion to anyone who's asking any question about fluid management or anything, they should read about those guidelines. And if you don't want to read, you want to listen, just check on the YouTube channel, because we had a session on it like last month with Dr. Sajjad. So if you read those guidelines, they don't recommend generally you should restrict fluid, because that will also impact your growth and everything. So what you can do is you can actually, you can use Lasix on and off depending on how, but I think the idea is, if you have to limit, you don't go lower than 120. That's the lowest you should go, 120 milliliter per kg per day. You can play between 120 to 140 range. You can even, I nowadays don't even restrict it, to be honest. I try not to restrict it. Because if you read the guidelines, and the guidelines are based on all the evidence they have. They feel like, this is the best we have, and this is what you should follow. And as I said, AAP never usually comes up with such kind of consensus, and this is a rare thing they came up. I think that should be taken very seriously, and people should just read it a couple of times, and they will be very clear how to manage PDA in all aspects of PDA management. And on a lighter note, Nasir, after this month, we should never talk about PDA for next 5 years at least, right?
Because I honestly think we hammered PDA in our brain. Yeah. But if I can chime in, Safdar, just one more thing. So we use the two words called as LISA and INSURE. And for most of you who may not be aware of what LISA and INSURE means, LISA means less invasive surfactant administration, whereby you give surfactant through a catheter into the trachea without intubating and without any positive pressure ventilation. INSURE, on the other hand, means intubation, which is IN, SUR stands for surfactant, and E for extubation. So INSURE means you intubate a baby, give surfactant over a period of 2 to 3 minutes, and then you extubate them. Now, there's a debate between the two methods, which one is right and which one is better. That's not a topic of discussion. But I'm going to tell you my unit policy. We do INSURE, we extubate, we put them on CPAP. If we have to repeat the second dose of Curacao, we do the second INSURE. And then we have a feeding protocol which force us to start feeding within 12 to 24 hours. We progressively build up the volume over a course of 5 to 7 days, taking into account many other factors. But when it comes to fluid restriction, the problem is that when you restrict the fluid, you restrict the calories. When you restrict the calories, you compromise the growth. So you have to take into account what you want to compromise, the growth versus PDA. And that's where people who want to treat PDA, they say, if I'm restricting the fluid, which we do not, and the Safdar do not, but there are some units where they restrict the fluid and they can go down to up to 120 ml per kg per day. But what happens that when you restrict the fluid, your calories are restricted and the babies are not growing. And that's when they say, let's bite the bullet, either treat it with an indomethacin, not indomethacin, ibuprofen or Tylenol, or just get it closed by a transcatheter closure. But again, in my personal opinion and my humble opinion, I think in the setup of Pakistan, where we are not taking care of 22 or 23 or 24 weekers, I think the PDA should be conservatively managed and should not even be addressed in any way, shape, or form in terms of anything, and just conservative management, and maybe using ibuprofen and Tylenol, depending upon what the unit policy is. Dr. Sajjad, would you like to add something, please?
No, I think, thank you very much, Dr. Nasir and Dr. Safdar. I think you have explained it very well. We generally do not restrict it to lower than 120 ml per kg per day. And but the fluid restriction is only for, say, 3 days or 4 days, because we prefer ibuprofen over Tylenol. And one of the reasons is that the duration of treatment with Tylenol is up to 6 days. But with the ibuprofen, you finish off everything within 3 days. And on day 4, we do the echo. And if the duct has become smaller or restrictive, we go back to the normal fluids and we think the duct is now closed. So it's only for a short period of time that the fluids are restricted. And of course, as you said, we have to keep in mind that by restricting fluid, we are reducing the caloric intake, which can affect the growth of the baby. Thank you very much.
So there's another follow-up question to what you said. So the question is from Dr. Faisal Khan. Thank you, Dr. Faisal, for your question. He said that sometimes hemodynamically significant PDAs managed conservatively. What's the BPD rate? And what was the BPD rate before? And then has it changed since we go for conservative management? So Safdar, how about you share your units, approximate incidence and prevalence, and then I'll share mine, and then Dr. Sajjad can also share his, and then we go from there. Go ahead, Safdar. Okay, I think Safdar has left.
No, I'm here.
Okay, sorry about that.
So the question, so let me put this way, that there is a strong association between BPD and PDA. But that doesn't mean that if you treat PDA, you have a lower BPD rate. So that hasn't been proven with any of the studies. Like, none of the, interesting thing is that all of the things which we are discussing, the ibuprofen, Tylenol, the management, the reason people go for conservative management is because the long-term outcomes have not changed at all. I mean, if there is some difference, that is usually short-term outcome. Like, you might see some improvement in BPD rates in some units. To be honest, I don't have the numbers in my head right now, what we have, but we have we are probably like a better or above average in terms of performance in BPD rates. I have to look. I have fallen off from, I'm getting old, so not remembering all those numbers. But
thank you for saying that. We all know that.
But our rates are actually not crazy, I would say. And we do have a BPD unit, actually, special BPD unit. And obviously, because we get the sicker babies here, like the more sicker babies, more premature. So that also comes into play. Like, you might say, oh, I have very good BPD rate here, but you might not be even admitting a 23, 24 weeker. So all these factors play into it. So I don't usually look at these things in this aspect, how much is your BPD rate? And I also have a personal bias about BPD, and I will say that BPD is a diagnosis which we defined. We ourselves have made a diagnosis. This diagnosis is linked with when we started using ventilators, obviously, and when we started taking care of babies who are extremely premature. That's when this came into play. If there was no vent, no premature babies, there was no BPD thing, right? So we made something and then we define it. So that's why there is a lot of controversy, which definition to use, what is the best way to assess it. We use mainly for students and junior doctors, we use oxygen at 36 weeks, one of the common criteria to call someone has a BPD, but they can have oxygen need for so many other reasons. So PDA is not a big factor, I feel, playing into BPD diagnosis. It has more to do with your prematurity and lung disease. So that's why I feel like if you're managing PDA and thinking like you're going to decrease the BPD rate, probably you have to think differently because it's a comprehensive package. What else you do, as Nasser mentioned, the LISA, and so many other things which can impact the BPD rates. So that's my less than 2 cents.
Okay. So my 2 cents on this one is that we are not a unit that accept babies from outside. We are not a regional acceptance center as compared to what Safdar is. So our babies are mostly inborn. So our BPD rate definitely had improved even if we take into account the definition of oxygen requirement at 36 weeks. And what we saw that before 2017, when we were not doing INSURE and obviously did not have a standardized feeding protocol and all those things, our BBD rate was close to about like 15 to 18%. And these days, since we have implemented all those things, including golden hour, the INSURE, and then feeding protocol and everything, and conservatively managing PDAs and not restricting the fluid intake. And by the way, the reason the growth is important is that as you grow the babies, the lungs grow. And as the lungs grow well, the BPD rate goes down exponentially. So our rate has come down to less than 5%. The other thing that I want to chime in on into this is that BPD has correlation with other long-term complications of prematurity, which include neurodevelopmental outcome, which also include things like ROP and everything. So if you have a low rate of BPD, then you will have a low rate of ROP, then you'll also have a better outcome in terms of neurodevelopment. And since I am on the chat, and I'm going to just answer this question briefly, that Dr. Khadim has asked, do we do serial echoes? Yeah, there's no hard and fast rule to do the serial echoes. A lot of centers have now adapted called as POCUS, which is point of care ultrasound, and they can do that, or sometimes they can do echoes as frequently as they want. But I don't think so there's any hard and fast and defined time that it has to be done every day, every other week, every 3 days, every 5 days. I think it depends on who is on and what they want to do with it. So there's no right and wrong answer for that, and there's no specific time. And Dr. Sajjad, would you like to add something? Thank you.
Thank you, Dr. Nasser. I think with regards to BPD, I think it is becoming like a forgotten disease now. We don't see what we used to see a classical BPD during our training times. That has disappeared. What we really see is what we call the new BPD, which is very mild disease, and probably most people like to call it chronic lung disease. And even the incidence of that is going down as well. And as you have said, it has nothing to do much with the PDA, but overall management of the preterm babies, including the better perinatal care and a lot of other things which we are doing, like antenatal steroids and the use of surfactant and good ventilation and all those things. So we don't see much of the BPD now. So that is a incidence which is going down both in numbers as well as in the severity of the disease. And with regards to other things you just said about the echo, we do it just for the diagnosis in the beginning by our cardiologist. And once we have completed the treatment, we do it. But as you said, there is no hard and fast rule. It depends upon who is on service and what he wants to do.
Yeah,
thank you very much.
Of the month.
Yeah. And my colleague can be on and he will be very fond of Tylenol, and I may be on and I'm fond of ibuprofen. So, yeah. But both have got the same outcome.
Yeah. Well, I think we are coming to the end of the hour. So first of all, hey, both Alize and Fatma, thank you very much for your presentation. Would you guys want to add one or two lines that you learned more while listening to this discussion, and what do you want to tell the future applicants and residency prospects applicant to how to deal with this? Because I think you were the first two who did this, and I'm so glad that you accepted the challenge and you did it. And this I'm pretty sure is going to be a good exercise in terms of not only building the confidence but improving your communication style. And then obviously, inshallah, when Fateh will watch this, he's going to just drive or flew all the way to New York or wherever Fatma is, and going to give her the contract out of the match cycle. But go ahead, then Fatma, if you have anything to add.
No, Alize, go ahead.
Okay, thank you. I just have one thing to add. There was a PDA tolerate trial in the AAP discussion, so where they basically kind of randomized two group of preterm infants. One of them got early routine treatment, and the other was just like the conservative treatment group. And what they showed in that was that the BPD incidence for the early routine treatment group was about 49%, and the one with the conservative treatment was 53%. So I guess just like you guys said, the bottom line is that conservative management can be associated with BPD rates similar or slightly higher than, intervention in some cohorts, but not clearly worse in many others. So that's it. And for everyone else who's going to be rotating with you, I just say best of luck, and they're going to be in for a very fun ride.
Yeah. Oh, I don't know about the fun part. I don't know about the fun part.
No, it's fun. It's definitely rewarding.
It's fun. And I say, you should step out of your comfort zone. Like giving a presentation, I would have been very nervous, but I'm glad that we did it. It's been a very good experience.
You want to say final words for Fateh to listen to you when he listened to this conversation?
What should I say? I just hope I have a good interview with him when I have it, and I hope he watches the presentation. I hope he likes it.
No, I think he is, after watching this and listening to your talk, he's going to, as I said, he's going to bring the contract to you instead of offering you a match cycle. So,
fingers crossed.
Yeah. Anybody else have any questions? Okay, Safdar, you have any closing remarks to say, please?
I was just typing in the chat, and the same thing I want to say, that there is something called subconscious learning. Sometimes things might seem very boring to you, like, what we are doing is very boring. It's the same. Why can't I just read on internet and learn from AI? But when you have such discussions, there's something called subconscious learning. And subconscious learning means you learn something you don't even realize. And I think I'm a big fan of it. And I think we should continue such activities. And I think the presenters did a wonderful job. And we should continue such things in future. If you guys need this platform, I'm happy. I'm happy to provide that. So any different ideas, we're not here to impose things on anyone. You're all gonna be brighter than us in future, better than us in future. But we want you to have a good start. And you have all the tools in your pocket, so you can actually utilize your best potential. And I will also say in closing that never worry about the destination, worry about the journey. Make your journey beautiful. And the longer and beautiful path you have, with difficulties which you overcome, with challenges you take on, it is more important to have a better life than thinking about the destination. And honestly, when you reach the destination, you will feel like, oh, I wish I was just still in the journey. So that's what I'm saying. You guys should never be disappointed, even if you don't match. Just continue your struggle. Life is full of struggle. Nothing is nothing is a finish line. And we believe, as many of us believe as Muslims, that this life is not even end point, even if you feel like, oh, you haven't achieved what you wanted to achieve. Sorry, mera jo bhashan hai na thoda lamba ho gaya, so
No. Safdar, keep going. Safdar, keep going. Yeah, they should hear it from you also, because I think this is very inspiring, that what you are telling them, and they all are either applicant for this cycle or next cycle. So I think it's it's a great advice that all of you are getting. Go ahead, Safdar.
Yeah, no, I'm actually done. I think that's what I wanted to say. Just stay strong and continue your struggle, and that's it.
अच्छा, हम समझे थे और लंबा भाषण है आधा घंटे का, तो हमने तो स्लीप वेयर कर दिया.
Yeah, thank you very much, Nasir. I'll just say one word.
Yes, sir.
About this word used by Nasir, by Dr. Safdar, about the learning. We call it learning by imbibition. You got my point. We call it learning by imbibition, just like the plants, they do.
Yep.
Yeah.
And I think most of them learned a lot with this whole discussion that we had.
Yes, exactly.
Yep,
thank you very much. It was a great session.
Thank you.
Thank you very much. Thanks. And thanks to the presenters.
Allah Hafiz.